Good evening, Commissioners. Today we will be presenting the health insurance information for you. And just so that you know, with us, I have Larry Reese. He's a Senior Vice President from USI. And with him is Roberta Ferdinand. She's our executive for our plan that assists us. And then Laura Calloway, she is our benefits administrator. So I wanted to make sure that you're aware and of who really is doing a lot of the work behind the scenes. Larry will be doing the presentation in just a quick second, but I did also want to let you know that starting next week, we will be having informational meetings with our staff on what we're proposing to you all today. Larry?
Thank you again, Sharon, and good evening to everyone. Thank you for the chance to be here. I'm Larry Reese with USI. We're your employee benefit consulting firm. I understand I'm trying to keep this to about 20 minutes, so I've got about 15 slides to go through. I'll try to keep a pace that'll allow us to do that, but it's important that I answer your questions to the best of my ability. If not, I'll make notes and we'll follow up accordingly. With that, I'll just jump right in. Is it going to let you do that? Hope we didn't just turn it off. I apologize if we did.
This happens a lot, don't feel.
Thank you for saying
like
that.
it's just you.
Let's go, yep. There we go. So I think everybody on council has a printed copy of the material, and I'll just quickly go through the agenda before I go through page by page. Big topic today. We're going to run through the State of the Union on the self-funded health insurance, so medical and pharmacy, and how that's been performing. We'll take a quick State of the Union look at MSK as musculoskeletal, PT as physical therapy. I think this group knows about that. Those programs have been remarkably successful. We'll take a minute and dive in on that, speak to some favorability on those programs. Then we have a benchmark comparative study for you at a very high level, but it speaks to the benefit plan design. And then we'll look at a 2-year strategy, migration of that plan design, and the draft alignment based on the survey data and the market research. Then a completely separate topic related in the sense that it's still about the medical program, but more the managing of care and what's going on with the clinic, how the health risk assessments all the employees go through and spouses go through a health risk assessment. What does that data suggest and what might next steps be? And then aligning incentives, so trying to encourage people to take some steps on the health journey and what those incentives are today and where we might take them and why we might go there. And then some next level programs that we think are appropriate in managing cost. Maybe as a backdrop to the whole conversation, I would just suggest to you that 1% of the people spend about 5% of the money. And so to the degree we can really help that 1%, it can have an impact as a self-funded plan sponsor on your experience. So I'll just offer that as a backdrop to some of the things I'm going to share today. Roberta, if you'll go to. Great. So financial performance, how are things going? Plan year 20 was favorable. Actual costs, so net medical costs, prescription drug cost, reinsurance or stop-loss premiums, and administrative fees were down 11% in 20 compared to the same data for 19. So that's favorable. Now that's about a $3.5 million favorability. So let's talk about this year. Fiscal year, July through May, so 11 months into the fiscal year. We had a budget forecast, so our underwriting projections turn into your budget, and essentially that's $30 million to 26. So you've got another little over $3.6 million in favorability. Again, about 11 to 12%. So things are running good. However, little bump in the road, and I've got some red font here just to call out. When you see blue font, that's my suggestion things are favorable. Red font, my suggestion things are not favorable. For the 3 months, I'm sharing that because this is being recorded, I'm told, and will be shared, community-wide. So I thought that might be a helpful hint on consuming the information. 3 months, year-to-date, most recent 3 months, March through May, are not favorable. They're flat. So just something to keep our eye on. 3 months doesn't a year make. but not favorable at the moment. Good news, fiscal year 21-22, everybody in the room knows there was no recommended increase to budget, and we also recommended no increase to employee payroll deductions beginning 1/1/22, so calendar year 22. And we had previously, I previously have been in front of this governing body, and we had talked about some plan design changes a few years ago. I'm back again to resurrect that discussion and reconvene on what that might look like. That's pretty much a financial update. So just comparatively now, not against your own budget or not against your year-over-year performance, but you to somebody else. How is Buncombe County's historical performance compared to a benchmark in the southern U.S. for municipal clients? And your consumption is going to be something on the magnitude of 16 versus a 13.5 if we look out at 21. That black line's around 13.5 or a little north of that. So conversationally, you're running about 15 to 17% unfavorable to a southern norm. Lots of reasons for that. We'll cover some of them. We've made some improvement. When I look at this, I see some nice, you don't like 18 over 17. 19 appears more favorable than the trend that 18 occurred. And then we made some great strides in 20. Can't say that that's all due to the population health and other strategies that we've deployed. We also get a little lucky with not as many shock claims. It's a combination of both, but you need to be doing both. And the journey right now with 20 is things are moving back in the wrong direction. So if you're looking at this like a salary analysis, because basically you spend money on health care, it's a dollar that would be spent somewhere else. This is a little unfavorable in that respect, and it's consistently been that way. I suppose that'd be the point of this one. Next, I'll just now move us into your 3 plans. You have 3 medical plans today, and you see the percentage of enrollment. So there's good spread there. 52% of the people elect the standard plan, and then the buy-up is 24 and the core is 24. So we gave you 2 benchmarks to look at. We could probably try out 5 more, but these are statistically valid benchmarks. I'll call your attention because the conversation is going to hone in on changing or considering a change to deductible and out-of-pocket. These are singles, so just to keep the grid a little less complicated, I get there's a lot on here, but family is not presented. There'd be commiserate moves in family, but what you have today is a $300 deductible, so individual is single, $400 and $650, and then you see the out-of-pockets, and you see it in comparison to benchmark. So all 3 plans are favorable. That might be one of the primary reasons why your claim costs on a per capita basis are higher than the benchmark data. You're more generous in your design features. I don't think that's news to anybody in the room, but I'm just kind of putting A and B together so that the story holds. Then the rates, the employee contributions, I think we already made the recommendation, no increase to 22. Here they are for 21. If that was the will of this governing body, then they'd be flat for 22 as well. So there they are in that respect. Ro, I'll keep us going. Thank you. So the summary on why you might consider changes. So we started this journey a few years ago, and we provided a strategic document then. It was basically some of the plan designs on the previous 2 pages. But what's gone right? Since we've been able to help with your reinsurance or stop loss, we marketed that across a wide, that's not on the ID card, it's not in the open enrollment guide. So who you buy reinsurance from and how you buy it is something that doesn't impact employees at all. So it allows you some leverage. It's not a Blue Cross thing. It's not changing carriers. Nobody has to change docs. It's a behind-the-scene financing mechanism, so that's gone favorable for you. Your prescription drug terms have gotten remarkably more favorable. And then the musculoskeletal program and the physical therapy things that have been done have been very helpful. So a lot of things going right, and I think that's why there hasn't been a budget increase for the last 2 cycles. But time to come back and look at that because of the three most recent months and kind of where you guys are in future forecasts. Healthcare trends 7 to 8%. So a do-nothing strategy which suggests the baseline increase in a $33 million, $35 million spend is 7.5%. So that's basically like saying consumer price index, inflation. When I say healthcare trends running 7.5, the do-nothing strategy is going to cost the account. Every client, every plan sponsor, municipal, corporate, privately held, healthcare inflation, healthcare trends 7.5%. So a do-nothing strategy, your costs are going to go up 7.5. So overall, just kind of making the point, now translating a previous page that was a graph chart, that you saw the differential between yourself and a normative. And now we're trying to quantify that 15 to 17%. That's about $4 or $5 million. So why? Why does Buncombe County spend 15% higher than normative data? You cover more dependents because the payroll deductions are more favorable. I don't think that's news to anybody in the room. You have a very low cost share. The plan designs are favorable. And the risk profile of the group is improving, but we're on that journey. And health doesn't change overnight, and people still need to be treated. And sometimes there's gaps in care that are identified that were untreated. So the correct treatment, and when the PT and the clinic and the things we're going to talk about today are really running, for a low turnover environment, you want to invest in those things because you're helping people improve their health. In the long range, that will save money. So that's the summary of why we're suggesting some of the things. So here are the changes. 21, these are the deductibles and out-of-pockets that you saw on a previous slide. So $300 for standard plan, $400 for buy-up, and $650 for core. If you let your eyes go to the middle of the page, you would see the suggested changes. So in this example, for a single person or an individual, deductible goes from $300 to $525. That's an increase of $225. I think you guys get it. And so you can kind of see the buy-up, $400 goes to $600, core goes $650 to $750. And so a little bit less, it's not the same number incrementally. There's a little method to the madness, trying to keep those in line or in a way that is plausible for the three to still have a shelf space. So when you think about this, people, when they pick a product to enroll in, there's got to be a little bit of shelf space between the three offerings. So there's savings correlated with this. And you see the cost savings for deductibles about $331,000. Out of pocket's about $454 to be specific. And then so while we were together, thought it was good to tell you more than 1 year. Maybe incrementally this is done. The year after that, so January the 1st of 23, you might consider some additional changes. Probably the biggest one would be UC standards no longer there. And the standard, if I could have made the chart work, I guess I would have put the HDHP, stands for High Deductible Health Plan, pretty prevalent in America, pretty prevalent in municipal America. HSA stands for Health Savings Account. That's basically like an IRA for medical. That's what it affectionately is referred to often. But we would introduce that plan as a third option, and standard would be sunset. If you're trying to consume it in the lineup, mentally I would just have you kind of pick it up in your mind and stick it over there past core, okay? It would be less rich than core, not to be as rich as standard. You'll notice the footnote. If we did, if it was the will of the governing body and the leadership of the county to launch a high deductible health plan and sunset standard, you could offer your employees HSA money. This might be very appealing to a certain portion of your employee base because they'd have dollars that would be funded by the county to set aside for future costs. If they didn't need those dollars and they were super healthy, the law allows those funds to be used to pay for Medicare premiums at retirement. So HSAs are popular. I'm sure you've Googled them. I'm sure you have friends that have them. But that would be the year 3 strategy if you wanted to go in that direction. The savings for the changes 1/1/22 between deductible and out-of-pocket are $331 and $554.
I'm sorry, can I pause you for a second? Go back.
100%, yeah.
I may have missed your explanation of benchmark and what that meant.
Yes, so this particular benchmark was more when high deductible health plans are deployed. So that's when we were showing you the 1,000 and the 4,000. 2 slides ago, we showed you benchmark USI and Municipal America, and those were a little different than that 1,000, 4,000. Not remarkably, but slightly different. Is that helpful to you? You're welcome. So a little bit of a move now. So plan design effectuates change immediately. The things that we're going to talk about next take a little bit longer to create change because it's all of us getting more healthy. Are we walking enough? Are we running enough? Are we exercising? Are we eating right? So HRA's health risk assessment And I think most people in the room know, because Buncombe County's been doing that for several years. But I need to get the flow and the order of events right, because I'm about to share something with you that will, first, we need to make sure we're all together on this. So health risk assessments are done annually. You ask your employees to do that. They're done in October. The results are provided to them sooner than January, but depending upon how those results happen for an individual. So what's an HRA? Biometric screening, blood pressure, glucose, HDL, LDL, BMI, weight. So those are the criteria that are looked at in a health risk assessment for biometric screening. Depending upon how that's scored, you get your results in January, and you could either have the favorable premium or the regular premium, depending on those results. And then there's an opportunity to see the clinic during a calendar year as an alternative standard. So that's all just kind of backdrop to, and should be kind of walking collective knowledge, but wanted to get that out there as we move into the next series of discussions. So how'd it go? October 20, here are your results for your HRAs. So if I was looking at Buncombe County, and Comparison County is somebody 4 years into the journey, okay? So where should I expect to be? Should you be there now? No. Should that be a goal? Yes. The aggregation of your employees and adult spouses taking health risk assessment and looking at their results, we now put your employee base into 3 buckets: low risk, moderate risk, and high risk. And so let's just pause. Low risk at 58. Wait, isn't that better than 63? No, it's not. We want low risk to be as high as possible. The larger percentage of the employees that are low risk, the better the disease burden in the group, in your case, in the county. So that's how you read this data. 55% of your members improved. So a year ago, that 9% was more like 13%, right? The high risk. So we had some migration, that's good. Clinics working, musculoskeletal programs working, PTs working. However, and this happens, gravity's pulling on all of us. Our people low and moderate risk, unfortunately, had some slide. And that's why these programs are important. That's why they're repetitive. That's why we try to keep it front of mind. That's why you have a wellness program and a chronic condition management program. Remember, we're trying to fight 7.5% trend. All hands on deck to just dial that down. Okay? So that's the results of your October 20 HRA.
Another question for you, sorry, to the previous slide. You had Comparison County. Do you mean that literally? Is that one other county that's
I do
analogous?
literally mean that
Okay.
as one other,
Okay.
as a bogey
Okay.
on somebody that's further along in the journey. Yeah, if you were asking me to kind of characterize how's Buncombe in year 2 stack up, I'd say pretty much as expected. So let's translate health risk assessment results year over year. Got some high risk, some medium risk, and some low risk. Now let's translate that into claim cost and percent of members. So for the 58% who scored low risk, 0 to 1, their claim cost on a per capita basis is $6,300. So you see how there's a direct correlation between the higher the risk factor, the deeper the disease burden, the larger the claim spent per person. Pretty logical, but good to see it, right? So 1,116 members, 58% of your membership, doing pretty well. And they don't really need to come to the clinic. So we're not proposing a change there. Current is how often they need to come to the clinic. So wellness visit requirements to show up to the clinic. Let's talk, and maybe there's a reason why. You've got some risk factors, and what do we want to do about those? For those with 2 today, the calendar year 21 requirement is for them to come to the clinic once. We're just asking it to go to twice. For those with 3 or more risk factors, they see the clinic once. We're asking that to go to 3. So yes, we are asking 32% of the people to do a little something different in 22 than they did in 21. We're asking them to go either 1 more time or 2 more times. Those touch points are critical in the change journey. Okay? It's just an opportunity to talk, maybe understand what they're consuming, how they're consuming it, or maybe not at all. Maybe there's a gap in care that needs to be closed. They don't have to go to the clinic. If they have an affinity to go to a personal physician, they would just need to get a printed copy of that. bring it into the clinic, and that's who's record keeping on whether we got the 2 done or the 3 done, okay? That's the recommendation and the suggestion. Now, I will call out, there's 27% of the members, 697 adult members who did not complete, it's a cohort. I got to have you in period 1 and period 2 to measure anything. You got 697 on the sidelines, and some of that's due to new hire, but some of that's just due to people not wanting to do it. 27% is kind of high for that. I'd say you get about, in any given benchmark study, about 10, maybe 12% just not interested. I'll pay the higher premium, leave me alone. So I'm calling that out now because we have a recommendation in a moment on a potential remedy for that. Okay? Is pace okay? Okay, I'll keep us going. Thank you, Ro. So a lot of data here. So we've moved away from clinic now to incentives, okay? This is health improvement incentives. So this is how a plan sponsor like Buncombe County tries to encourage a consumer to engage, okay? So what you have, so we're not recommending any change for 22 to employee premiums. Already said that. I'm going to say it again because we're not recommending it for wellness either. No change for 22. We are suggesting a preferred plus rate for 23. What's a preferred plus rate? A preferred plus rate would be today, 58% of your people, if they take the 22 HRA, right? We're going to do that in October 21. And then they turn around in October 22 for 1/1/23, take the HRA. I mean, no reason to assume it won't be a high percentage. It might not be 58, but they would already gain favor for the preferred plus rate, okay? So let's look at high risk and medium risk. We're asking those people, that's the 32%, we're asking them to improve one criteria. Glucose scores could get better. HDL, LDL scores could get better. BMI could get better. Just an improvement, not in every category, in one category, and they would get the preferred plus rate. If they didn't do either one of those two things, and we got into calendar year 23, and they were willing to work with the clinic and still try to make an improvement and actually achieve an improvement at that point in the calendar year, not the beginning, but let's just say they finally fixed something in their health profile in June of that year, then they would get the preferred premium reasonably following the June date for payroll administrative purposes. So there's always a way to get the preferred plus for someone who's willing to come along in the program, okay? That's what I'm trying to say. The regular does go up a little bit, and the preferred stays, is a little more favorable than the regular, and the preferred plus stays the same as the current discounted. So why tonight? Why are we telling you about the 23 journey? Because this has got to be communicated sometime in 21. The consumer will take action in 23, and then the implications of those actions will take place January 1, sometime in 22, and then the payroll deduction change would be in 23. I apologize, I made a mistake in the dates. A lot to keep up with. Okay, so, hey Larry, why the increase in the regular rate, that last bullet point? Remember on page 9, I told you that we have 697 participants not engaged, which is around 27%. This would be a vehicle, so see how the regular rate goes from $53 to $61 for those in the standard plan? It's conversationally $9, but that's not a month. So $100 a year. We're just trying to put a little more incentive to, do you mind coming off the sidelines and participating in the program? That's all we're trying to do is get them to engage with us in a health habit change. And with your clinic, that the county's invested assets in that clinic and in the PT program, right? So y'all have deployed the resources to help people make improvements. We're just asking them to lean in and help themselves a little bit. Okay. So now we're going to segue again. This is just an update. Musculoskeletal program's going great. Claims are going to bounce. You had 3.6 million in 18, 4.5 million in 19, and now we're down to 3. I would love to tell you 5 months into your musculoskeletal program, we made 1.5 million disappear. We did not. Things are going well, but I would say that your moving average on musculoskeletal spends probably closer to high 3s, low 4 number, and the favorability that you've got in the PT program's probably worth $50,000, $70,000 a month. That's basically what this is saying. Through March, you have 285 members. Just to help you make sense of it, the county's probably got about 3,800 enrolled members. Adult members are probably 3,200. And so to have 285 join the musculoskeletal program, look, as we all get older, knees and hips and shoulders, that's the way it works. And so engaging people before they need surgery is beneficial. And lots of times PT can prevent surgery if they get good PT and they stick with the physical therapy regimen. So we estimate the program savings to be north of 300, and our original projection was 3. That's some of the reason for the favorability. That was just an update for the good of the group. We'll keep going, Ro. So condition care program, and I know we're really getting deep in the weeds, but stay with me. PPCN, that's the old Asheville project, so most folks have probably been around long enough to remember and know that. I think it's been good for the county, good for the city. I think it might have seen its life cycle. Clinical care programs need to be updated and evaluated. If it's about engaging people and saving money, I'd say this one's seen better days. There's low engagement right now, and there's not good evidence of savings. There's probably a better way home. So one of the recommendations is that you sunset that program. There's implications to sunsetting that program. You have 390-some people enrolled in wellness program with the county today that get partially subsidized drugs because they're enrolled in that program. That'll go away on January 1. So the recommendation is that you sunset this contract. I'll leave that to staff and leadership on when that exactly happens, but we would sunset the 3 plans that those 390 people are enrolled in on January. That's the time to do it in the Blue Cross cycle. You renew January 1. So that's when that would take place. So a little bit of a downside to those people, but it's not having the effectiveness that you want. Those dollars could be better spent by the county in a different way. So I'll talk about that now. There's a new approach, plan member advocate. So let me just put a couple of facts on the table. So the county had 346 people identified for case management this past year. So what could that be? That could be post-surgery, and I wasn't engaged. That could be I'm a diabetic, and the data says I'm non-compliant. I haven't had an A1C exam in a while. That could be a number of other things that aren't coming to me right this second. But you only had 21 of those 346 engaged, around 6%. Honestly, not completely unique. People just don't return phone calls, and they don't like talking to their insurance company. You had 13 members at 192 inpatient stays complete a post-operative or a post-inpatient stay call. So neither one of those would be favorable statistics. I'm making a case for behaving a little different. We think you can get some lift, and we've had that number validated by Blue Cross, about $500,000 if we could get case management up. Our recommendation, after going to market and talking to some other partners, is Synergy would become your primary advocacy group and condition care and care navigation partner. That's a mouthful, but they would do a lot. You'd have an RN, CCM, stands for Certified Case Manager. They're quasi-clinical, and they know about behavior change. A lot of behavior change. So I might have a chronic illness. I might have Crohn's disease, and before we can ever treat the Crohn's disease, we've got to treat me emotionally and get me in a place where I want to make changes and I accept what that lifestyle change might be. I have to eat different, have to consume some pharmaceuticals that have a side effect. I don't like the side effect. I like to eat what I eat. I don't like side effects. So RN and Certified Case Manager are really important ingredients on the change journey. Think high school coach, whoever, piano teacher, whoever leaned in and really helped you make a behavior change and was shoulder to shoulder. That's what we're talking about here. It's just clinical this time. The cost for this program is going to run you about $191,000, and the ROI is going to be a net ROI of about $350,000. That needs ramp time, so that's a 12-month journey. But that's the recommendation to the group, and we're informing you of that one. Autoimmune, so everybody knows lupus. Autoimmune diseases, there's a broad spectrum of autoimmune. 3 big ones: MS, rheumatoid arthritis, psoriasis, and Crohn's, inflammatory bowel disease. So why are we singling out autoimmune? If you know anybody with autoimmune and you have any inclination of their healthcare journey, it's a mess. It's self-guided, it's difficult. There are 4 or 5 different attending and treating physicians. Nobody's really quarterbacking care, and they go for care. It's complex. They're a complex patient. They're not easily identified and diagnosed. And what this program does is says, okay, you got 151 of them. But by the way, we're getting better at diagnosing them, so they were probably always there. They just weren't, I say we. The clinical community is getting better at diagnosing people with autoimmune disease. And so because of that, you already had that patient, that employee, that covered spouse, but they were bouncing around in the healthcare system with no diagnosis. And we're finally getting better at it as a country, as a clinical community. And you're spending around $2.6 million today. 1.6 of that's on pharmaceuticals. And so I'm going to scare you a little bit and tell you that 32 people spent that 1.6 million. Yep, so stay with me. 151 people have it. 32 are taking drugs for it. You spent 2.6 million with 151 people, 151 people, but of that 2.6, 1.6 million was drugs, and only 32 people spent that money. Remember the beginning of the meeting, I said 1% of the people spent 5% of the money? This is part of that 1% right here. You got 4,000 belly buttons covered, and we're talking about 151 of them, okay? So, specialty medications average 50 grand. So this program is entirely designed to lean in to the people with an autoimmune. I wish we had this program for every disease there is. We don't right now. And this one's marginally beyond pilot phase. There's 6 clients doing it. Anyway, we think you might be interested, and it might be a wise investment to consider deploying this program for your folks who would like to participate. Not mandatory, not required. They're individually outreach to. And if they'd like to join the program, it's free to them as a consumer. Why would the county want to offer something free to a subset? Because you're spending $2.6 million on 151 people and 32 1.6. I think it's probably a good investment to lean in on them and see if they're being, in the care navigation world, if they can be helped with their disease state, and this program's designed to do it. No guaranteed ROI on it. My sense and my conversations with all my clients is if you don't do this, you're going to continue to spend money on their pharmaceutical consumption, and they're going to move all around the healthcare journey because they're sick and they don't feel well and they're not sure why. And they frankly just get bounced around in the healthcare system. So this is designed to kind of center that, ground it, put a net around it, and start to effectuate change with some people who designed some pretty smart clinic. Dr. Hanaway designed the program through the Cleveland Clinic. If you know the Cleveland Clinic, that's like saying Mayo, right? It's legitimate. That's a lot. Thank you for letting me run through it. I'll summarize. We'll go to the next one. So, if it all boils down to savings, the plan design changes on page 7 were worth a little less than $800,000. The complex care navigation is worth about $352,000. We tossed autoimmune in there, but I want to be very specific right now. There's no savings associated with autoimmune. So you could delay that program and just, you spend what you spend, kind of like you're doing right now. It doesn't make it a good or bad decision, it's just an alternative. But if you deploy it, you could effectuate change downstream. And hopefully some of those 32 and 151 join. But together, those two are estimated at saving a little over $1 million in a calendar year on a generally, conversationally speaking, budget of $35 million. So it takes 3% out. So I got to put quotes around savings, and I got to kind of now say it's really future cost avoidance, because I've been telling you trends run at 7.5. So that 35 million number is going up 7.5% a year. We just got to have all hands on deck to try to drive it down, and here's $1 million that maybe takes out 3 points. So I am grateful for your time tonight. I'm sorry I tried to move at a decent pace and cover quite a lot of ground, but it's been a pleasure to be here. I'm happy to take questions or whatever's best.
All right, thanks, Larry. That was a lot of information, and I think you did a great job covering it. Commissioners, are there any questions at this time? We're not voting on anything tonight, of course. This is to share information with the commission, and there's going to be a process to get more engagement with county employees, and then, so it's just starting the process. Any questions? All right, thank you very much. We appreciate you being here tonight and providing an overview of this. It's an important policy, and we appreciate the good work being done and ideas for the future.